So anyway, we completed upperly lower limb fractures and the remaining part of the some of the general topics and others. So I think we will just briefly will can we go through upper limb fractures or upper limb is finished, no? Actually, for you, upper limb fractures are finished or not?
Yes, sir.
Yes. Any revision done? Any revision done for upper limb fractures?
No, sir.
No. Okay. I will take one or two important topics, revision topics of the upper limb. So, so can we go through the fractures of the clavicle first? This is only revision class, huh? Remember, because finish all these upper limb fractures. Huh? So briefly, I will tell. Just so when we come to the fractures of clavicle, it's a mainly it is due to the fall and the outstretched hand. This revision class are helpful for you to write to your exam. Hmm? So in a nutshell, we'll tell these important points. Okay, and the mid-shaft fractures are most common, and but the outer one third of the fractures are unstable because of the pull of the ligaments and the torn of ligaments like coracoclavicular ligament and all these things. And distal third clavicle fracture is one good example. This is a quite unstable. It's fixed. So this is an example for distal third clavicle. So basically, these clavicle fractures are common in children. And when you see the patient, a subcutaneous lump over the clavicular region may be prominent, and pain will be there, crepitus will be there, and outer third fractures are easily mislead for acromion dislocation also. So how will you proceed? So for any, of course, X-rays, AP and lateral yourself cannot be possible. Chest view, APU, you should take to rule out the fracture. So clavicle, some of you, please, some of you mute yourself. Background sound is coming. And 30 degrees cephalic tilt view is required. Hmm? Or if there is sternoclavicular injuries, because sternoclavicular injury means the patient is very much prone for chest injuries. So chest injuries. So that's why we need to take CT scan also to rule out the chest injuries. S- Students, are you able to hear me? Are you able to hear or not?
Yes, sir.
So why somebody is talking behind? Hmm? So you have to listen fast. If any questions are there, you can ask later. Okay. So coming to classification, it's a middle third, lateral third, and middle third. We already told this one. Okay. And if you see the physical examination, so this is the picture. So first evaluate the deformity and displacements and compare on both sides. Then only you will come to know deformity. And then inspection, it will be like this. And so in AP view, it appears like this. Huh? And in 30-degree cephalic view, it tells you whether it is displaced inferiorly, superiorly, or anteriorly or posteriorly like this. So 30-degree cephalic view is also sometimes required, but rarely we take. Normally we take AP view. Treatment usually, clavicle is a horizontal long bone, but sometimes it is considered as vestigial. So it's a usual treatment is a non-operative. Of course, nowadays the program has changed. So treating the clavicle with the internal fixation is nowadays quite common. So you have to apply the sling And normally in non-operative cases in the undisplaced middle third and proximal one third, middle third. So a sling can be taken out after 3 weeks or 4 weeks. If at all want surgical fixation means go for a plate, open reduction fixation with plate. Usually the outer third fractures they require plating. So now complications include early complications if it is very near to the sternoclavicular joint. So it leads to pneumothorax and damage to the subclavian vessels, which are lying quite inferior to the clavicle, and the brachial plexus. And the late complications include non-union, especially lateral mounted, which is mainly due to pull of sternoclavicular ligament. Malunion is also quite common. Shoulder stiffness, and this one is an example for open reduction and plating. Understand? So now, so sometime we can put the internal fixation with the intramedullary elastic nails also. So especially in pediatrics. So coming to the scapula, of course, the scapula. 85 we are going. We cannot complete all the fractures in this one. So coming to the humerus fractures. Coming to the proximal humerus fractures, usually occurs after the middle age because of the osteoporosis. And the mechanism of injury is also same due to fall and outstretched hand, and it is associated with the dislocation of shoulder. And classification is the needs classification. Hey, needs classification. One second, just a second. I'll make mute for 1 second. And due to fall and outstretched hand, and sometimes the proximal humerus fractures are associated with the dislocation of the shoulder. The classification is the needs classification. Needs. Okay. Why it is not moving? So, according to the needs classification, there are four parts. Okay. Based on these four parts, it is classified: greater tuberosity, lesser tuberosity, surgical neck, and humeral head. So, see, this is the humeral head. This is the humeral head, and this is the greater tuberosity, lesser tuberosity, and surgical neck. So, humeral head means it is definitely maybe anatomical neck. Anatomical neck is always proximal to the surgical neck. Usually, the surgical neck fractures are quite common and compared to anatomical neck. So, this is the vascular supply, mainly by lateral ascending branch of anterior humeral circumflex artery. Remember this. There are two circumflex arteries here, anterior and posterior. They form a ring-like structure. So, mainly supplied by the anterior humeral circumflex artery. So, this is the needs classification. One part fracture, especially the minimally displaced, only one part. Anatomical neck, surgical neck, greater tuberosity, lesser tuberosity, and next one is the fracture dislocation. This is the six types. So, one part fracture, two part fracture, three part. See here, if you see this picture, this is the only anatomic neck. So, either anatomic neck or surgical neck or greater tuberosity or all these single fragments are involved, then it is called one part fracture. If involvement of anatomical neck or surgical neck and more than one part, this is a two-part fracture. And three-part fracture is from from greater tuberosity, because greater tuberosity is a cancerous bone here, so it leads to comminution. So that may be classified into grade three type part, three-part or four-part fracture. Hmm? So finally, there may be fracture dislocation also. So what are the clinical features? First of all, whenever you see an inspection, you'll find a bruise on the upper part of the arm. That indicates, okay, there may be some underlying fracture. Okay. Then next is the pain, crepitus, restricted shoulder movements. Hmm? Then X-ray of the shoulder, AP and lateral you need to take. If necessary, if it is comminuted more than three parts or two parts, then you need to take the CT scan also, 3D CT. Then you have to analyze whether to fix or not. Mean either to go for surgery or conservatively. So the whether to decide whether to go for surgery or not, it depends on the fracture pattern, viability of head, whether head is viable. Blood supply is lost or not, and bone quality, and implants, and patient age and comorbidities. All these things you need to check. So for the okay, if you come to that particular treatment, minimally displaced fractures need no treatment except sling and rest. That's all. Sling and rest for 4 weeks. 3 to 4 weeks upper limb. So fractures usually unite after 6 weeks. Completely. And a two-part fractures is surgical neck fracture. You can manipulate and immobilize an arm sling, even though it is a little bit displaced. Elbow and hand exercises to be encouraged. Hmm? So, in case of difficult fractures, percutaneous pins, intramedullary pins with the tension band wiring. So, if it is a greater tuberosity fracture, better you can go for pin and tension band wiring. Hmm? And greater tuberosity fractures are often associated with anterior dislocation of the shoulder. That is very important. When you reduce the shoulder, automatically the greater tuberosity will come in contact with the main shaft. So automatically these also will come into place. So then you can do close reduction and apply the sling. If not reduced, then with a small incision, you can put either some suturing, interosseous suturing, or cancellous screws. If it is a single non-comminuted graded tuberosity fracture, simple graded tuberosity fracture. And anatomical neck fractures are rare. Already we told, we discussed. In young individuals, treat with the screws. But in older patients, you need to put the prosthesis, like hip prosthesis. For fracture neck of prosthesis, for fracture neck of femur, what prosthesis you put normally? Already discussed, no lower limb. Fracture neck of femur, what is the name of that prosthesis you put? Hmm? Martin Morse prosthesis. Martin Morse. Okay. So here knees process. Here the process is called knees process. So three-part fracture also we have to go for surgery again. And four-part fracture no alternative. We have to go for surgery because all the fragments are displaced. So that is again hemiarthroplasty, knees process. And the complications include vascular and nerve injuries, especially the commonest nerve that is involved is the axillary nerve. Axillary nerve. Okay, axillary nerve. What is the supply of axillary nerve? Hmm? What is the motor supply? Hmm? Okay, this one is the so. two-part fracture which is fixed with the plate. Hmm? So open reduction and internal fixation. So hemiarthroplasty is like this. So this is the Needs process. So which is used for the hemiarthroplasty of the shoulder. So this is the Needs process. So other complications include avascular necrosis of the head of the humerus, stiffness of the shoulder, and malunion. Especially malunion is quite common, being a cancellous bone. That is the one. Next to the coming to the fracture shaft of humerus. Again, same fall on the outstretched hand mechanism, as well as another mechanism is the fall on the elbow with arm abducted. Fall on the elbow with arm abducted, which may cause oblique or transverse fracture due to the bending force. This is important. Another one is the direct blow to the arm, which leads to comminuted fractures. And of course, in elderly people, humeral shaft as well as proximal humerus fractures are also common due to some pathological conditions like osteolytic lesions, metastatic lesions. These are quite common and they lead to fracture. An introduction. So coming to the humeral fractures, they traditionally, since age old, orthopedicians, even orthopedicians used to treat conservatively, means non-surgical, with good results also. Nowadays, there are some senior surgeons who are treating all shaft fracture, mid shaft fractures of the humerus conservatively. So, because strong bias is formerly existed against surgical intervention. So, of course, nowadays, in many places, surgical procedure is getting followed. So, in case of fracture shaft humerus. So, in fractures above the deltoid insertion, in fractures above the deltoid, proximal fragment is adducted by the pectoralis major because deltoid lose its force. So then adduction will be taken place by pectoralis major. In lower shaft fractures, the proximal fragment is adducted by the deltoid in lower shaft. Opposite, vice versa. And in these cases, the nerve that is commonly injured is the radial nerve, shaft 2. What are the deforming forces here? Example of a fracture distal to the pectoralis major attachment and proximal to deltoid tuberous and adduction of the proximal fragment tuberous. This is the deltoid attachment and this is the deltoid and this is the pectoralis major. Hmm? So of course this is an example of fracture distal to the deltoid tuberous. So deltoid is inserted into deltoid tuberous here. And so the proximal fragment is abducted and shortening occurs at the fracture site. So classification is mainly based on this thing AO classification, American Orthopedic Association classification, and the fracture descriptor location. How do you describe the fracture? Based on location, whether lower one third or upper one third or middle one third, pattern and impact, whether it is low energy fracture or high energy fracture, and also whether it is closed fracture or open fracture. These are important points. So this is the mechanism, diagrammatic representation. So one part, two part, one, two, three, C1, C2, C3. So comminuted fracture. Then so on physical examination, what are the cardinal signs of the long bone fractures? All will be seen. What are the four important cardinal signs of long bone fracture? You need to tell because you have attended so many classes of fractures, upper limb as well as lower limb. So, what are the cardinal signs of any fracture? Complete fracture. Can you tell? Anyone? What are the cardinal signs of fracture? Pain is a sign or swelling? Pain is a sign or symptom? Pain is symptom. So the cardinal signs are swelling, deformity, crepitus, and abnormal mobility. These four are the cardinal signs of any fracture. Swelling is not a sign, it's a symptom. Okay. And also you have to look for associated injuries like nerve injuries, vascular injuries, and you have to document it properly in case of open fractures. And if on clinical examination, patient arm is painful, bruised, and swollen. Hmm. So you have to check for the radial nerve by active extension of the MCP joints and active extension of the wrist. So active extension of the wrist here it may mislead because of extensor carpi radialis muscle is supplied sometimes with a branch arising from proximal to the injury. Sometimes the radial nerve is supplying to the extensor carpi radialis longus, which is a wrist extensor. So if the radial nerve is divided proximal to the fracture and giving a branch to ECRL, patient will do this active extension of the wrist. In that case, it may mislead. So you have to do investigations like AP view X-ray, lateral view X-ray, shoulder joint X-ray, elbow also to be included. And if the patient had nerve injuries, wrist drop, you have to go for nerve conduction studies and check where the nerve is impacted. All these things. And so, if necessary, you have to go for CT and MRI also sometimes in case of closed pathological fractures. So closed treatment is already I told you olden days they used to follow the closed treatment where initial immobilization with either a coarctation splint or hanging arm cast. Remember these two words: coarctation splint and hanging arm cast. I will tell you what they are. With a conversion to a functional brace. In the second stage, only up to 5 degrees because this is a non-weight bearing, so we can accept some sort of angulation. So 30 degrees of varus deformity is also acceptable, and 3 centimeter shortening is acceptable, being a upper limb. But in lower limb, especially in tibia, not more than 2 centimeter shortening is acceptable. Hmm? And the surgical treatment includes that depends on injury related forces as well as patient related factors. So, what are the indications of open reduction internal fixation of humeral shock fracture? Suppose failed closed treatment, the patient is was treated with closed reduction or later it's failed due to loss of reduction or poor patient outcomes or failure of union. That is an indication for open reduction. And open fractures must be treated with surgery, no alternative. And vascular injury, you have to do surgery again because we need to explore the vascular structures where they are injured and to be repaired. And floating elbow. Floating elbow. What is floating elbow? Can you tell me what is floating elbow? You must know it. When does it occur? If there is a fracture of the distal one third of humerus, as well as proximal one third of forearm. So distal one third of arm and proximal one third of forearm. At both sides, if there is a fracture, so elbow appears to be a hanging elbow, floating, if appearing to be a floating between the two fragments. So that's why it is called floating elbow. So intra-articular fractures must be treated with surgery. Hmm? Only open fractures and those with vascular injury present absolute indications for surgical intervention. So, coming to the patient factors of the indication, head injury patient, you have to do, no alternative. And chest trauma, you have to do. And multiple fractures, that is also. Patient unable to be upright and bilateral fractures of the humerus must be treated surgically. And pathological fractures, definitely we have to go for surgery. Hmm? All these things. Operative treatment in completely displaced and in combinated fractures, in multiple fractures, open injuries, segmental fractures, floating elbow, radial nerve palsy, non-union, and all these things are the indications for operative treatment. Open reduction internal fixation can be done by a compression plate and screws. Of course, nowadays locking plates are available. And next one is the interlocking intramedullary nail, of course. So for the dish, so for the sharp fractures, especially middle one third of the sharp, we can go for intramedullary nail because intramedullary nail got so much advantages. Hmm? It can be done closed method. You can do without any major blood loss and periosteal loss. And in children, especially, we use elastic flexible nails. Elastic flexible nails. So, surgical treatment based on mainly plate osteosynthesis, intramedullary fixation, external fixation. Okay. Then, plate osteosynthesis means osteoporosis will develop, locking plate. So, these are example for the locking plates. See here. So, these are the bionic important plates which are accepted in osteoporotic humerus, in osteoporotic bone. Hmm? Intramedullary nails, of course, this one. This is the intramedullary nail. Okay. And so, coming to the next one is the external fixation. So, external fixation is also one important thing. Here, especially if the skin condition is not good, associated bones, infected non-unions, humeral shaft fracture with a neurovascular injury. Neurovascular injury is already there. You cannot already existed. So even though after repair of the nerve also cannot be regained. So in that case, better go for axial fixation. So complications. What are the complications of axial fixation? Early complications include vascular injury, brachial artery damage, nerve injury, especially radial nerve palsy. Hmm? And late complications include delayed union and non-union. Okay. Of course, radial nerve injury is quite common, even with the fractures also, not only the due to axial fixators. Transverse fractures of the middle one third are the most commonly associated with the neuropraxia. A spiral fracture of distal one third, the Holstein-Lewis fracture. Yes. What is Holstein-Lewis fracture? This is important. Important Viva question or exam question for you. Holstein-Lewis fracture is a fracture of the distal one third of the humerus associated with a radial nerve injury. That is called Holstein-Lewis fracture. Usually, this is a spiral fracture. Okay. Then coming to the other complication, vascular. So here most commonly brachial artery will be injured, especially in case of gunshot injury, especially in case of gunshot injury and then stab wounds and vessel entrapment by fracture fragments, all these things. So, brachial artery is the greatest risk of damage in proximal and distal one third of the arm. So, in those cases, you have to go for arteriography or angiogram to see where it is injured, how much is it injured, and all those things must be repaired. Okay. So, a last complication may be include a joint stiffness. The last complication is the joint stiffness. So these are the early and delayed and late complications. So which are very important. So if they ask the fracture shaft of humerus, you have to write the mechanism of injury. So clinical features, then complications of fracture, then management, conservative as well as surgery. Then go for postoperative complications. All those things you need to write. Okay. So this one must be read, you people. Hmm? So this is the today's revision class, especially clavicle fractures and proximal humerus fractures and shaft humerus fractures. In next revision class, we will go for fractures elbow and fractures around the elbow. Okay. So that is also one important topic. Hmm? So that's all. This is the today's revision class for you. You people must read, otherwise there is no point, because without reading, simply telling so many times is useless, waste of time for you and us. Then only you can write the exam. If you read only, you can write the exam properly. Hmm? Next time I will ask few questions. If you don't tell, so we will discontinue the classes for you people. Okay.